All right, so I'm just going to move on now to the Chiari Malformation. So we had 3 sessions on Chiari Malformation. In the first session, we asked John Oro to give a talk on what is the actual goal for surgery? What are you technically trying to achieve? And he gave a terrific talk on how to do posterior decompression and how that relates to helping with the headache, although, of course, I think even John acknowledges that we don't fully understand how the headache happens and what is fixed by the surgery. We then had Cormac Marr talk about some more precise measurements of Chiari Malformation, what's normal, what's not normal, and how that relates to symptoms. We heard a talk about some current MRI techniques that look at CSF flow at the craniocervical junction, which we think is likely to be very important in the pathophysiology and generation of symptoms with Chiari Malformation. So it's more of a watch this space kind of field. Then Paulo Bolognese I wanted to challenge him to talk about how he manages patients who have persisting headache after surgery, because I wanted him to say that I'm sure even Paulo doesn't have a 100% success rate, right? So what does he do? And he gave a terrific talk about what sorts of things he would look for in terms of a patient with ongoing headache, even though they've had what might appear to be a technically successful operation. And then we had some talks about cognitive disturbance and quality of life, some interesting research out of Akron from the Kyary group about what is the underlying structural changes that relate to cognitive disturbance in Chiari Malformation patients. So as I said at the beginning, this is a real focus of research, I think, at the moment that's really important, because this is a real issue. Then we had Doug Brockmeyer talk about scoliosis, and in particular there's a question about how best to manage patients with these conditions and scoliosis. I think we all accept that syringomyelia causes scoliosis. So when a patient comes with scoliosis, if they've got a syrinx, it's probably appropriate to treat the syrinx. But there may be some questions about whether that changes the final outcome or not. But one of the big questions was, for patients who have Chiari Malformation but not a syrinx, does that cause scoliosis? And there's evidence that it probably does, but how it does is really unclear. So that's an interesting field that needs to be sorted out. We had some talks about some other disturbances, so breathing. So a lot of patients have obstructive sleep apnea. How does that happen? How is it assessed? What's the best way to manage that? And similarly with swallowing dysfunction. And then Roger Kula, who I'm sure he won't mind me telling you, is recovering from recent surgery, so he couldn't physically come, but he gave a talk over the internet by Skype. That was terrific. So he gave a talk on managing balance and hearing disturbances in Chiari Malformation. So again, focusing on what's causing those problems and how we might best manage those. And then we heard from Renee here about managing Chiari in children, and it's clearly a different issue in children. There are lots of factors that need to be taken into account when looking after children. We heard a talk about benign Chiari Malformation. So for patients with Chiari Malformation that wasn't particularly symptomatic, the subsequent need for them to have surgery was actually very low. So that was a very reassuring finding. We had a talk from Dorothy Loth about the Chiari 1000 project, which is run out of the Akron group, and this is where patients, I'm sure many of you know this, you upload your images and clinical information. And so if you think about that pyramid of evidence, it's probably fairly low on that pyramid in the sense that this is not any kind of randomized control trial, or how the data are collected is fairly selective. But nevertheless, there is an incredible wealth of information in that database. They've got, I think, 1,300 patients in the database with images, and so lots of opportunities for analysing that database. And so Dorothy talked about that. We heard from John Oshinsky, who's an engineer from Atlanta, about new ways of using MRI to see how the cerebellum is stretching and moving in patients with Chiari Malformation. And I think this is likely to be a field that will lead to real answers about how Chiari Malformation causes symptoms. And then we heard from Claire Rusbridge, who's a vet from a veterinary neurologist / neurosurgeon from the United Kingdom. Sorry, not from Claire. We heard from Dominic Marino, who's a vet from Long Island, I think. So he has a lot of experience with Cavalier King Charles Spaniel dogs who have Chiari Malformation and syringomyelia. So he talked about the outcome for those. And then we had the consensus talk where we looked at these questions. So the first question really was, can we define... Lynn, why don't you come and come up the front? Not as strong as the surgeons.
Oh, no, I'm not.
No, come and join us. So Lynn is an engineer, so not a clinician, and you probably know we've worked together for a long time, trying to understand the physiological issues that underpin syringomyelia, and so she's very smart. And I've asked her to be here because there will be some issues where she will be best placed to address those. So with Chiari Malformation, we started with the question of, is there a specific measure or way of diagnosing Chiari Malformation? And I think the answer there is that everybody agrees that the long-standing rule of a 5mm tonsillar displacement through the foramen magnum is not the appropriate way to define Chiari Malformation. It's obviously more complex than that, and some further work is going to be needed to really define what it is. And so we heard some of the research around, and some of the subsequent papers about some specific measurements, CSF volume, change in pressures and displacement across the foramen magnum, that are probably going to lead to us being able to be more definitive about how to diagnose this condition. I think we all agreed that we don't know what causes headache in Chiari Malformation. There are various theories around whether it's pressure on the dura, raised intracranial pressure when people cough and sneeze, whether it's impingement on the nerves at the upper part of the cervical spine, or whether it's something to do with the stretching of the cerebellum, and so more research is needed here. And then we talked about what are the goals of surgery, but bearing in mind that since we don't understand the underlying causes of the symptoms, the goals of surgery are kind of speculative. Now, as I said earlier, a lot of focus is placed on the how, and this is what we're talking about here, is how to do surgery. And I think we all agree on what we think are the current goals of surgery, which are that we want to have a CSF space. Cisterna magna is the CSF space behind the cerebellum, so we want to see that on a post-operative scan. That's a goal. If there's any compression of the brainstem or upper cervical cord, we want to relieve that. I think we all agreed on that. But importantly, we agreed we should be avoiding complications. So avoiding CSF leak, avoiding pseudomyngocele, avoiding serious complications. And so there are issues around technical approaches to surgery that avoid complications, and that's we would all clearly agree on that. Are we trying to achieve reduction of strain or movement of the cerebellum? We don't know, and as I said, some of the research is focusing on whether that is actually the technical goal of surgery, and if that is the technical goal of surgery or one of the technical goals of surgery, then it would be important to assess that. We don't know. We all agreed that either not enough or too much decompression is one of the reasons that people have ongoing headache. So that if you are going to do posterior fossa decompression surgery, we agreed that there is likely to be an amount of decompression that is appropriate. There was a question of whether the method of surgery is actually very important. As you may know, there is emerging, particularly from China, and Polo has adopted this, a more minimally invasive approach where rather than taking off bone and expanding the dura, the approach is to resect the cerebellar tonsils through a more minimally invasive approach. And that seems attractive, but again, I come back to the question of we don't really know what it is we're trying to achieve. So, but it may be that if the goal really is to achieve a CSF space without the tonsils pressing in at the foramen magnum, then that's a reasonable approach and would achieve those goals. And so there might be different methods of surgery that achieve the same goals. We all agreed that the indications or the threshold of symptoms or imaging findings that might be acceptable or lead to an indication for surgery are not yet clearly defined. I think we all agree that for very symptomatic patients with a severe Chiari malformation, that surgical decompression is appropriate, but at the other end of the spectrum, there may be very mild Chiari malformation patients with very minimal symptoms, and they would not really need surgery. And there's a spectrum in between. Okay, and we talked about the clinical features in children. We all agreed that the children are different. We talked about what we think are causing the cognitive changes, and as I said, there's some research looking at that, whether that's something to do with the part of the brain, the top part of the brain, that where we traditionally think conscious activity is happening, and how the Chiari malformation might affect that. And I think there's agreement that there are likely to be structural changes there, but again, more research is needed. We agreed that syringomyelia is important in scoliosis, but the role of Chiari malformation and the indications for surgery when somebody presents particularly with scoliosis and how that might impact on the progression of scoliosis are not clearly defined. And so more work is needed there. And then the other symptoms, sleep problems, swallowing problems, balance and hearing, whether or not surgery helps those, again, not clearly defined, and whether they are indications for surgeries, I don't think well accepted. So that's my overview, and unless anyone's got any particular comments about that, my plan now is to go to the questions. Does anyone have any comments about what we covered in Kyary? So the first question is number 7. Is there a chance that my 1.5-year-old daughter has Kyary as well? Is it commonly seen as a genetic disorder? What signs should I look for? And I think probably Renee, you might be the best person to answer that question.
Yeah, of course, yeah. Let's
Maybe
put
it's
it
better
here.
just to take it off and pass it around. Good morning. Oh, perfect. So is there a chance? Absolutely there's a chance. We do at least agree that in certain cases there might be a genetic underpinning to Kyary. However, there's been pretty extensive research, mostly out of Duke University, that's looked at a variety of different genetic factors. And they have identified some similarities in cohorts of families that have multiple patients affected by Kyary. But it's not a specific coincidence, meaning there's not one specific gene that has been identified as causing Kyary. It seems to be a combination. And within that gene pool, those are also present in patients who have other disorders and who don't have Kyary. So it's not very clear and distinct what the genetic underlying mechanism might be in those patients that have multiple family members affected. In general, and people can disagree with me, I don't recommend multiple family members being screened unless there's a very strong family history that's already been defined, or if there's another patient in the family who has symptoms that would be concerning. Those would be the 2 times I would recommend other people get screened for it. In terms of symptoms in kids, it can be variable and it can very much depend on their age. So as they approach into the teenage years, the symptoms become much more consistent with what you would see in an adult, meaning headaches, specifically headaches that occur in the back of the head, associated neck pain, balance disturbances, swallowing difficulties, snoring, ringing in the ears, sensory deficits in the upper extremities, things of that nature. But as you go down in age closer towards infancy and early childhood, it can be much more challenging because those children are not necessarily verbal. If they are verbal, they can't always articulate things. They may not understand what they're experiencing. So sometimes it may be as simple as a lot of irritability that doesn't improve after that typical colic age has passed. Children who are having difficulty meeting their gross motor milestones, they seem to be more clumsy than other children. Those who have very poor sleep habits, and it seems to be related to abnormal respiratory patterns at night. Children who are not able to advance in terms of their feeding, so at a certain stage they should be doing baby food and then transitioning to table food. If they're having trouble swallowing during that process and managing the coordination of those, that can be a common symptom set. But it's difficult and it's very age dependent.
Okay. Andy?
As the token Brit in the audience, I'll just keep it simple for me, because I suppose I think about this in a simplistic way. The way I talk about it to patients is I say that yes, you can have children, your children can get this, but does it matter? We know that in the population, up to 1% of people have a Kyary, but less than 1% of that group actually need surgery or treatment or have symptoms from it. So it's a tiny proportion. So in most people, having a Kyary, or what we'll talk about definition of Kyary, I'm sure will come up, it is normal. And it's only when you're getting bad symptoms that it becomes a problem. And so it's only a problem for your kids if they're getting bad symptoms from it, not if they necessarily have it.
Roughly 10%. 10% of my patients would have a family member.
So, yeah, and I agree with what you've heard already. And when families ask that, have to keep in mind the chances are low, and I agree with Dr. Studley, 10% or less seems to be. And if about 1% of the population has Kyary, then there's a whole bunch of people with Kyary right here in Buffalo and in any big city. So clearly it's telling us that a lot of people are doing okay with Kyary. We don't really know what the factors are. So I just guide the families that if the child seems to be having what Dr. Reynolds outlined in the child, more irritability, those kind of things, or in an older child, the more adult symptoms, the suboccipital headache and those kind of things, then to discuss it with their neurologist. But if they don't have any symptoms, certainly a scan is not needed.
The next question is number 8. A general question about how best to manage things on a long-term basis. Now, perhaps John.
Yeah, in terms of post-op diet, exercise, activity, etc. Number 8, yes. So yeah, this is a fascinating area. I think we're having a lot of growth in understanding this. I see wellness in 6 realms, basically. And clearly, number 1 is sleep. Life, your day activity is a catabolic activity. We're breaking down and using molecules and chemicals, etc. And night is anabolic. That's when we build and restore. Sleep dysfunction is a high problem in our country and frankly worldwide. And so I always start with sleep. I mean, your day starts with your sleep. So protect and respect your sleep. There's a lot of work being done in sleep, so there are many guides available for you. Number 2 is diet, and I'll be very brief. The bottom line is going back to a more natural human diet will improve your health without question. Yesterday, there's an article of propionic acid that is put in foods like bread and cheese. They have longer shelf life, and it protects against mold. And now there's at least one study that's suggesting it's related to the rise of autism in our society. So the bottom line, the short answer is nutrition. The more you steadily move to a natural diet, don't do it radically, because that you'll never stick with it. So fitness. Fitness is more powerful than we realize. I'll be very brief. If you want to really grow brain cells, then high-intensity interval training is really among the top activities you can do. You can learn about that. But any exercise or physical activity is huge for brain health, if you will. Then we have well, let me jump to connectivity. Connectivity means social relationships are very important to your health. That's what we were designed for, if you will. There's a lot of evidence. Nature time. Nature time is huge. We have removed ourselves from the natural environment. I'll be brief. It's an English study. They took men, basically, they put a portable EEG. They asked them to walk through the busy town. Not knowing why, but they just needed to walk around and go into a park setting, a non-threatening park setting, in other words, open space, green space. Clearly difference in your EEG. In the town, your brain is processing a lot more because that, oh, that sound was just a car door, or this person that slightly bumped into me is not a threat or not. That's going at a subconscious level. You go into the park setting and your brain waves synchronize. Water, and the color blue is being studied. If you're interested, the book is called Blue Mind, and the effects of water. So nature time, I think, again, is huge. Think of how we and I don't want to overdo it, but think about how we disrupt our sleep. We basically then turn off these bright lights and tell the brain, I'm ready to sleep. And your brain says, I have to make this stuff for you, melatonin in particular. So blue blocking glasses if you use digital media at night. There are other nighttime glasses if your spouse loves bright light and you want to go ahead and get your biorhythms, etc. So the bottom line is there's a bunch of factors that allow us to improve our health. The last one, the fourth one actually, is what I call rejuvenation. It's harder to do, but we all have to pull back, whether that's prayer, meditation, reflection, reading, etc. We have a high-powered life. Last point, basically our ancestors before farming and civilization worked 30% less at least. They chose the best environments to live. They had, they could pick, and they had no rent, they had no mortgages, et cetera, et cetera. We're in a high-pressured life. The more we bring that into our life back, might help us.
Okay, and probably the next question is number 9. That probably follows on from that. Is are there any physical limitations that you put on patients after recovering from Kyary surgery? Again, John?
Well, there's no, and I'll pass it along, I'm sure everybody, I've not seen any agreed upon standards, if you will. There's basically no evidence of what we should allow and should not allow, so they're clinical impressions. And if we're talking about post-operative, well, pre-operative, there is now information. It's in the pediatric literature. It's in sports. I think it was 1,600 young people that participated in sports. I think there were 160 or so collisions that were looked at, and they looked at the risk. And these kids had Kyary, so it was a Kyary group. They looked at the risk of the sports collision to worsening in them, and there was no serious worsening whatsoever. So the pediatric organization does not recommend keeping kids from sports activities. It makes us clinicians a bit nervous to see a very tight Chiari malformation without symptoms, but that's what the literature seems to show. So post-op, very briefly, we're fairly strict in our lifting restrictions. It's first month, no lifting over 10 pounds. Second month, increase about 5 pounds per week. And basically then for the first year, I ask them to avoid activities that can throw them around. In our state, snowboarding, skiing, but four-wheeling, any other activities like that. But after that, other than a contact sport with direct hit to the head, because most people are going to have the arch of C1 removed, and a downward force can split that arch anteriorly. It's extremely rare. I've only seen one case, and it's because post-op, because she was thrown through a windshield 30 feet. Fortunately, she was cared for well. So I think long-term, Kyary folks that are doing well can do what they feel like they should do.
Yep. Andy, Renee, you agree?
Yeah, agree. I spoke to a patient who had been told many years ago that because she had a Kyary, she couldn't have children. And the amount of misinformation out there is incredible. So, yeah, I mean, I think it's being sensible. Certainly, if I have a patient who has a Kyary and a syrinx, and they're symptomatic when they do particular things, it's common sense. If it makes you feel worse, then maybe it's not the right thing to do. But generally, people can do most things.
Yeah, I'm kind of split in the middle, meaning I think patients who are asymptomatic and don't have a syrinx probably are relatively safe to participate in most activities. Those who are symptomatic or have a large syrinx, we all have those one-off cases where I cannot attribute it to anything else other than the head injury and the associated Kyary who have had decline. So I'm a little bit less enthused about them participating in high-risk activities. But what defines a high-risk activity is very difficult, because even the non-contact sports, you can have contact. Each one of us could be at risk of falling down the escalator on the way out, so it's very difficult to define. To go back very briefly to the question before, and I promise I won't take too long, but I agree with everything that Dr. Oro said. But I think we just need to reiterate that it's a commitment. It's not easy. Even those who don't have Kyary and don't have the need for a decompression, it's hard to focus on nutrition and sleep and rest and mindfulness. But it really takes dedication, and you really have to do it for your overall wellness. So it's hard. The screen's always there. It's always enticing. It's hard to get out of bed sometimes when you're not feeling up to it and get that exercise. But there's even a study out of Buffalo within the last year that shows in the concussion population, light activity helps people improve quicker and recover quicker. So there's clearly a link, and we do need to push ourselves a little bit. So just reiterating the dedication that's necessary even when you don't necessarily feel up to it.
Okay, next question. Yeah.
I don't know if you're going to cover this when you talk about EDS, but does the advice remain the same if it's a person that has Kyary with EDS?
So the question is the advice the same if a person has Kyary and EDS? Yep. Yep. Okay. All right, next question is 15, and it's basically saying, should you have a whole spine MRI if a Chiari malformation is diagnosed on a brain MRI? Well, I certainly get a whole spine MRI. I'm looking for, it's uncommon, but I'm looking for a syrinx, I'm looking for diastema myelin, I'm looking for tethered cord. Yeah. Right.
So my own approach has evolved over time. I used to always do a full spine. That was just sort of normal and typical. What I found is the likelihood was quite low in the population I was seeing overall, and the expense is significant. So we then basically think about the thoracic spine and think about the lumbar spine. For instance, in the lumbar spine, we use Dr. Bolognese's tethered cord questionnaire. That guides me to think, should I go ahead and look if there's a tethered cord? And it's true, you can have a syrinx in the thoracic spine and have minimal signs below, but most Chiari-related syrinxes are going to be in the cervical spine. Certainly if I see a cervical syrinx that is extending lower, or I see some abnormal signs in the lower extremities, very brisk reflexes, for instance. So I've been selective, but I don't know what the real answer should be.
Renee and Andy, do you get whole spine?
I say yes, and that's routine for me. I agree it's a low likelihood that you find something, but even one of the cases presented yesterday was with this large anterior CSF collection that came into the abdomen, and you wouldn't have otherwise picked that up. And now you're treating the wrong disorder if you're treating the Kyary. So I'd rather identify those one-offs, even though there is a cost set off and the likelihood of finding it is low, just to make sure that I'm doing the right thing for the patient.
But that's why the exam and the questionnaires are what clues me in. And in other words, if they're relatively asymptomatic and the questionnaire is relatively negative, no. But if there's enough there, disturbance. But I agree that that's not perfect. And ideally, yes, having a whole scan would certainly answer the question.
Yeah, in the majority of patients, I agree. I think it's also important just to remember that a Kyary isn't caused, there are different causes for a Kyary. And, most people, when we were talking about the genetic basis of a Kyary, people were assuming, it's one thing, it isn't. So if you have a small posterior fossa, that's one cause of a Kyary, and you can understand why that's passed on to your kids, going back to the genetic question. But there are other causes. So if you've got a chronic CSF leak, if you've got a tethered cord, if you've got hydrocephalus or something above. So if I've got somebody who's symptomatic and their Kyary has been picked up, it might have only been picked up on a cervical spine MR or even a CT. I would get a full neuroaxis MR if they're symptomatic and I need to assess them and work out what their best treatment is going to be. If it's one of that vast majority of patients, and I'm seeing them more and more who had a scan, saw a Kyary, have no symptoms attributable to it because they were found completely incidental, nothing to find on examination. I agree with John. I don't necessarily go and do a whole neuroaxis MR, but I warn them of the things to look out for. And sometimes they then come back and say, well, actually, thinking about it, I've got this, and you then investigate more.
And I agree with Andrew that certainly everyone that we see with Kyary must have a brain MRI. That Kyary may be what we call secondary. There may be other issues, elevated brain pressure, et cetera.
And I should give the caveat that even though I do adults and peds, the majority of my patients are peds, so I can't always ask them, a 2-year-old, do you feel like you have to go to the bathroom? Do you empty your bladder? Do you have pain in your legs? So it may be more of just a comfort zone for me to get the imaging to rule that out. So.
But on the other hand, they need
Makes
a
sense.
general anesthetic.
Pardon?
They need a general anesthetic, right? So,
They do need a general anesthetic, so as opposed to sending them for the cervical and then seeing, the syrinx goes lower, and now I have to send them back again under another general anesthesia, it's better just to do it all in one stint.
I think that what comes out of that is it's clear that it's not an absolutely definite thing that a whole spine MRI necessarily needs to be done. If you go to see a neurosurgeon and they don't do it, they may be thinking these things, right? And so then it doesn't mean that they don't know, right? That they've made a decision for themselves that it wasn't worth the expense and that there's no clinical indication to do the scan. Doesn't mean they're not an expert and not up with the current play. Then there's quite a few questions that I probably could group together, which is about pain management, and particularly around naturopathic or natural treatments, cannabis in particular. So maybe we could just group those together into non-surgical treatments for Chiari malformation, particularly for the pain.
So yeah, it's a fascinating area, but there are quite a few, and I ended up putting a list together, if you will. So I wouldn't forget any of them. Meditation is certainly something to think about. It's kind of disconnecting from all that continuous stimuli. If you consider meditation, I see people that have the concentration type of medications be more difficult, so look for a mantra-based meditation. The most common mantra-based meditation is transcendental. A lot of professionals use that. Jerry Seinfeld, for instance. Michael J. Fox controls his Parkinson's disease with that technique. So that's one technique. There are others, but again, the concentration-based ones are difficult. Yoga is certainly another very good way. It's surprising. It's not something I did before. I thought it was kind of just to get flexible, and I don't do much of it, but it's really about strength and balance and focus. It's a fascinating Tai Chi. Tai Chi is fairly prescriptive. I mean, you really have to dedicate some time, but yoga trainers can help you with that. But there are actually breathing changes that affect cardiac function, and there's some evidence for brain chemistry and reduced inflammation. Sleep we've touched on. That's a huge part of pain control. If you disrupt your sleep on a routine, and what are the things that people provide advice, and that is get a consistent sleep schedule, even in the weekends. Don't think you're catching up, because you're not. You're disturbing your circadian rhythms, basically. Sleep is dark. That's what produces the melatonin. And so we lived in an environment with the lights fading down. So some people that are called biohackers, there's a number of biohackers worldwide now that are using technologies to try to improve themselves. There are true dark glasses, for instance, that block those certain wavelengths, etc. So, and again, I think I've mentioned it to you, but nature time, social connections are important. Pain control. Had a young woman who had bad syrinx. She'd been treated on several occasions. And what she said is when her pain was most severe, and it was a very neuropathic, unusual pain from a large syrinx, having her dog lay on her legs or nuzzle up against the legs brought pain control, so pet therapy and those kind of things. So, and there are more. Explore. You got to find something that fits you.
Andy?
And living in Colorado, I've certainly had patients over the years that go right straight to marijuana, but I do think that this CBD oil is an option for some patients.
I think the only thing to add is that there is no perfect algorithm for each patient. I've had patients who respond very well to physical therapy and others that do nothing. I've had people who respond very well to acupuncture and others think it's a waste. So I think you have to be open-minded. You have to try all the options that are out there. I can't imagine the frustration of going through multiple and not having them work, but there are several different alternatives out there. I think the question becomes, how long do you try each one until you recognize or agree that it's failed and move on to the next? But again, sometimes it's the last one that you try that ends up being the one that works. So be open-minded, try whatever is there, and see which one seems to benefit you the most.
Okay, great. The next question was 23, which is how to diagnose symptoms returning after successful decompression, in particular looking for craniocervical instability, tethered cord, CSF leak, scar tissue, POTS, etc. What additional testing do you recommend beyond standard head, spine, MRI?
So you're saying recurrent headache with what looks like a successful decompression?
Yes,
Yeah,
but I would take that with a grain of salt, I guess.
Sure, yeah, exactly, yeah. Well, certainly you do have to evaluate the surgery itself, and it can look opened, the posterior fossa, but if the arachnoid was not open, which is acceptable, that's the inner membrane, but there is a hole in it, it can trap spinal fluid in that area. So if you're told your area looks wide open, ask for your operative note. If they did an arachnoid sparing procedure, which is acceptable, if there's a hole in it, they could trap this fluid that it's going to look wide open. And fortunately, those people respond real well by taking out that blockage that's caused by the thin membrane.
And you can pick that up on dynamic imaging, so CSF flow study?
Just CSF flow study is where I've been able to pick it up, and it's fairly unusual, but it's a hidden cause of headache. She had 2 opinions and said everything was wide open, and it certainly was not on Cine. So ask for a Cine study if they say it's wide open, but you feel like you're not better. If the arachnoid wasn't open, most of the time it's going to be opened. Then there are the pressure conditions. I think these are the most worrisome, and actually at least the high pressure condition is not uncommon. And that, the old name is pseudotumor cerebri. The new term is idiopathic intracranial hypertension. It's important to know that whether that exists or not. It's more common in women, more common with elevated body mass, but I had a 17-year-old with a very severe Chiari malformation. She had swelling in the back of her eyes. It's the only part of the brain we can see. Marked papilledema, as it's called, and our accomplished neuro-ophthalmologist found that it was her acne medication, minocycline. In Britain, there are 117 legal cases for high brain pressure from the Mirena IUD. The Norplant, I guess it's called Norplant implant for birth control, has been associated. Problem with pseudotumors, there's a whole long list of conditions. Most of my folks that I see don't have those, so it's related to body mass, and therefore a strong nutritional approach can lower the brain pressure. So high pressure's probably one of the most common hidden conditions, and I'll just mention one other because there's a long list. But the other that's worrisome, and it's fortunately uncommon, is hidden spinal fluid leak. So if we all can imagine a swimming pool with floaty toys on top. If you open up the drain in the pool, those toys are going to come down to the drain. So if we're leaking spinal fluid, the back of our brain is going to hang down. And if it's thought to be Kyary and they have a surgery, the brain's going to hang down even more. So there are neurological signs that you have to push your radiologist because some might be less familiar, but there are certain sagging signs of the brain that we look for to make sure you don't have that, fortunately, relatively unusual condition. Briefly then, there's occipital neuralgia. Maybe you've got a spur on the cervical nerve root up high in the neck. There are a few other less common causes, but yeah, if your Kyary decompression looks good, don't assume that you can't have another type of headache. That's the other thing. Is it migraine or whatever? Yes, sir.
Have you noticed increase in post-decompression patients with pseudoterm and pseudo?
Sort of resulting from? No, but I've had some patients, and the most impressive to me, she was around 250 pounds. I explained the surgical options. She had a 12-millimeter Kyary, not pointed, but very crowded. And she asked me, what else can I do? And I said, well, if you lose body mass, you might improve. And that I know of, I never operated on her, but she beat Kyary surgery. I have a younger woman, not as severe, and she took a nutritional approach to managing her Kyary. I guess what we've done is try to get her back to those folks that have Kyary and are okay, but then you have pseudotumor, the swelling condition, and then she's symptomatic and is probably going back to living with her baseline Kyary in a good way. So that's why nutrition is so important.
It's important to have a neurologist that you work with these patients, isn't it? So a neurologist who's familiar with Chiari Malformation, who understands that the operation was done, for a good reason, and that ongoing headaches, may have other causes, and so it's got to be someone you work with commonly, isn't it?
Yeah, and that's crucial, and obviously that's going to depend. And I think in this conference and other conferences, there's clearly we need an educational movement within our own professions to better recognize this disorder.
So then question 24, the question is, do the cognitive or psychological problems get better after surgery? And I think I addressed at the beginning is that this is clearly an issue. There are people working on it. I know in our place we're doing pre- and post-operative neuropsychology testing and matching it up with imaging findings. We're trying to look for correlates of what changes. But in terms of answering the question, in practical experience, do the cognitive changes get better? Before I ask the panel, I will say that my own experience is in general, things don't change, but sometimes they do. I've had one patient where preoperatively, really significant cognitive changes, and when she came for the first post-operative visit, she said to me, "Doc, you must have thought I was crazy." And I'm no longer crazy. And she was completely changed cognitively. So it does happen. Is that?
Well, we don't have the science on this, and clearly we need it. So what we have is general questionnaires, if you will. We developed an outcome scale called the Kyary Symptom Profile. We haven't looked at the subset of questions. My own clinical impression is that they do improve more than not, but I had the percentage, since it's not been measured, is unclear. But some of it is also in a sense of how re-engaged are they with life. And a number of people become re-engaged in life. They're feeling better about their work, their social activities, etc. They're going back to sports, etc. So they seem to be functioning at a higher level, but we haven't answered the question scientifically.
Yeah, I think I learn something every day about Kyary, and the behavioral and cognitive side effects were things that I traditionally didn't think improved much, and I don't think as an isolated symptom I would be super aggressive about doing surgery up front to manage that. However, I have had a handful of patients who have had very objective changes afterwards that weren't the primary focus of the surgery but clearly improved. Most recently, I had a 35-year-old guy who was diagnosed with bipolar and been treated his whole life with lithium therapy. That was not the purpose of the surgery, but afterwards he was clearly a different person. He's been weaned off his medication, is doing fantastic, and his mood and his affect is clearly different. And then a 13-year-old girl with pretty significant autism who afterwards, the family didn't even need to tell me because just walking in the room, she was smiling, she was making eye contact, she was laughing, which she hadn't done that prior. And the family then, of course, told me that they had noted those changes as well. So again, I learn every day about this condition, and I think I've been more impressed by some of the opportunities for behavioral and cognitive improvement, but I still think it's a minority of the patients that we see these dramatic changes in.
Can I make a comment there, Renee? So I think we probably need to be cautious that what you've described It may be that the diagnosis of autism was not correct, that that kid was actually suffering from the Kyary.
It may have been, but in this specific case, I do believe the diagnosis was correct because there was a lot of verbal deficiencies, a lot of
Yep.
social things that have been going on as well. But I don't diagnose autism, so you could absolutely be correct. Yeah, and even the bipolar could have been inaccurate as well.
We don't want to go away from this conference having all the autistic kids being operated on by today. So,
Correct.
I mean, you know, these things may emerge, but we just need to be cautious. Yep. Next is question 27, and I know Lynn's been very keen to answer this question. So, does anyone have an interest in exploring the role of CSF and/or blood flow in the progression of Chiari malformation, and could this be done using dynamic MRI?
So I'm here for the one question.
Wait till we come to the CSF physiology.
All right. The short answer is yes, and in fact we are doing that currently. One of the real challenges we have with this condition, particularly in a smaller country like Australia, is that we don't have a lot of access to patients. Don't often come to Sydney to see Marcus, and then we'd like following them, over time is actually the real challenge here. We've got some really exciting new methods for looking at CSF flow and blood flow using imaging, using phase contrast methods, so we can measure both the movement of the tissues and also the movement of the fluid and also the blood flow. And we are actually currently working on that. So that's the short answer. But the difficulty is really trying to get good measurements over time, and particularly trying to understand what changes over time might occur in Chiari patients to try and give us a hint as to who might get a serous and what the causes of that might be. So I think there's both a role for those sorts of cine imaging, repeat studies to try and understand the mechanism, but also to try and help develop a better predictive algorithm for who's going to have secondary complications.
Question 35. What is the reason a person with Chiari cannot go on a trampoline or in a bounce house? I don't know my children do that. I have heard some neurosurgeons give no restrictions whatsoever regarding contact sports. We've kind of covered that, but it was the trampoline thing that I think we haven't probably covered. Personally, I wouldn't have a problem with it, but
I think there's a lot of controversy over whether those activities are limited or not. I personally don't limit patients from participating in those activities unless, as you alluded to before, they seem to be inciting events that cause them to have symptoms. I think if I was asked if a patient is symptomatic during those activities, what is causing it? Certainly there's a lot of theories. One of the theories we have is whether the pain is from a stretch on that tissue, and you can imagine as you're going up and down, that stretch may be exacerbated. We also similarly hypothesize that the dura, or the covering of the brain, is one of the sources of the pain. And if that tissue is already full and now you're doing this sort of activity and gravity's kind of putting further exertion and pressure on that dura, could that be contributing to the symptoms? Do we definitively know why? No. And does every patient with even symptomatic Chiari have exacerbations with those activities? No. And I personally don't limit people from participating in those unless they have symptoms while doing it.
Can I answer the end of that question? Let him. If you read down the bottom of the question, it says, can he wants to sign up for football, soccer. Yeah. So I would let him.
yeah.
I just wanted to ask a question that, because we've talked about activities a number of times,
Yep.
and the only reference I've heard outside of my world that people inform and talk about roller coasters, and that being a significant triggering event for symptomatic, at least with EDS, and the simultaneous consequences that had followed.
So the comment is being on a roller coaster, right, a triggering event.
So I happened to be on the board of neurosurgeons at the time that Six Flags came in for our opinion, and this was probably 15 years ago, about their roller coasters. The bottom line, as the engineer explained it, their concern is in these very high-speed rides, they're heading in this direction, and then all of a sudden you're going this way. And what's happening is the brain is still going that way while the skull is. So they were having injuries, not just head injuries or head problems, but also some cervical discs, etc. It turned out that the incidence was very, very low. Hundreds of thousands will ride, and those chances of those kind of things occurring. Although Six Flags did go on to have more, like the modern systems are supportive. So I've allowed people to go back to roller coasters. I do ask them to wait a year. I don't know why. I'd like people after a major operation to have a good year under your belt. You know, they want to go snowboarding, et cetera, et cetera. Get a good year under your belt. You've just been through a lot. And I've not had someone come back and say, I did the roller coaster, et cetera. But it's those G-forces that are the main concern. And also what I ask them to do is when they go to the park, say after a year, do the old rides first. And if you're doing okay, try the high speed, send me a letter or email me or whatever, and no one has let me know.
This is purely based on my own thoughts and has zero data to support it, but I think there's a difference in style of roller coasters too. So there's some that are very smooth in their ride. Your protectus and harness is coming from the top, and you have, I think, much more stability in that ride. There's others, for those who live locally, like the Predator, which is the wooden roller coaster, where I get off it and I'm like, oh my God, you know, there's just a lot of jolting back and forth. So I think you have to kind of use your best judgment. And would I be thrilled about riding that style? Probably not. And just to give you some insight, you know, a lot of these questions have come down to the pediatric literature because that's really where patients in that age range are wanting to participate in roller coasters and sports. And there were two surveys, one in 1998 and one in 2004, and I presented this data as well, that was survey-based at these large pediatric conferences. And there's completely inconsistent opinions about what we should recommend for this patient population in terms of activity limitations. So it's still one of the areas that I think we have very little understanding of. And even the people who make the judgments that you can't participate, I don't think they have strong evidence to support why they do or don't.
And just brief follow-up, and when we send them out the door and allow them to do that, I do remind them that we're all running a low grade risk every single day, so they have to put that in perspective as to how meaningful that activity is to them in their lives.
I'd just like to say we have rubbish roller coasters in the UK. Having been to places like Kings Island, they're much better here.
Yeah.
So with Dr. Huff, with PEDS patients, I have 3 children that have all been decompressed. And as far as like sports and participation in gym and PE, at younger ages, teaching them the skills is one thing and letting them participate to that level, but they're not able to control what other kids do, so they're more limited because we can't control if Joe is going to throw the ball at your kid's head, but we can control working one-on-one with your kids, so it's more that aspect.
That's exactly what I tell families. I say we can't control what other people do. I do think theoretically there's a slightly higher risk if you took a big head impact that you could have exacerbation or new symptoms or an acute decline. I kind of leave it in the family's hands of if you want to assume that risk and your child is extremely interested in football and that's their whole life, then with this knowledge you can make that decision. But I completely agree with you. Just like driving on the road, we can't control other people's actions. You never know what that other player is going to do. And there are certain sports where that's lower risk and versus others. I always say we love golf and bowling in neurosurgery. Very rarely do you get hurt doing those. So.
Okay. Question 37, I think we've answered already. That's about hereditary issues. And so 38, it's really about why is it that some doctors don't recognise that Kyary symptoms are more than just the typical headache. And so I suppose the question really is, do we accept that Kyary causes a broad range of symptoms?
It's certainly in our questionnaire, a number of our patients do check off the GI disorder issues. The thing is also there's so many other conditions that it can result in GI disorders, so it's a bit hard to sort out. There's the mast cell activation syndrome, where these immune cells secrete a lot of histamine and stuffy nose, and and congested. They may have skin rashes or skin changes. And with that disorder, there's certainly a certain amount of GI complaints as well. I don't have my own impression of whether those improve or not. And I guess the short answer is eventually we will need a detailed enough outcome study that digs in to what symptoms improve or not, so we have an idea. But what I tell my folks is that they come in with a long list of symptoms. I never know that each one, I mean, sure, the suboccipital headache is more likely the Kyary I'm looking at, but otherwise, I never know whether these symptoms are all related or not, and I let them know. I also, what I'm looking for is there a pattern of symptoms that's consistent with what I see on the scan, okay? But anyway, clearly we need more detailed view in all these different symptoms.
Yeah, I agree. And just to add, I would reframe how the question is stated. I think there are certainly providers out there who are very black and white. This is your headache, it's not Kyary related. If this is your symptom, it can't be. I think collectively as a group of people who have interest in Kyary and who treat many patients with it, we completely agree that there are several organ systems that are probably affected. To what degree the Kyary is causing it versus other things, we don't quite know. And I think what is more appropriate to take is that, you know, if somebody has a frontal headache, I won't tell them it's not from the Kyary, but what I will tell them is what the literature currently supports that we have, which again is minimal, but what the literature supports is not that your headache is not from the Kyary, it's just that it doesn't necessarily seem to get better with the surgery. So we try to focus on the symptoms that, or at least I do, the symptoms that seem to have a stronger correlation with success of surgical outcome, only because I don't want to put a patient through a surgery that is not benign and certainly has risks, for the pictures to look great afterwards, but for them not to feel any better. I don't think that there's an advantage to that scenario. So it's more what information we've gathered and what seems to benefit most from surgery.
Yeah, I do exactly the same thing. I say, look, I understand and acknowledge that a lot of your symptoms are likely related to Chiari malformation, but in terms of just deciding about surgery, let's focus on the occipital headache. 42, do you find patients with Kyary have persistent cough? I've not seen that myself.
No, I haven't either. Maybe a show of hands. Who's troubled with who has Kyary with persistent cough? A few. Okay. Yeah. I mean, it's not impossible. I have a young man right now with Kyary with probably first time reported. We haven't treated him. His palate continuously spasms. So I guess it's not out of the question. I mean, the cough circuits are certainly can be affected. So it's interesting. Thank you.
Have you seen cough? No. But that's interesting. There's enough there to make it an issue that we should think about. Okay, and then 43, this is the tough question. How many patients really are symptom-free after decompression?
There are some. I will say I treat a unique population of mostly pediatric patients, and there is some literature to suggest that they'll do a little bit better than the adults, and we don't know why. It may be the longevity of how the time frame of that they've been having symptoms, and that we're getting to them a little bit quicker, so there's a higher rate of recovery. I think it also depends on the symptoms that you're talking about. So for instance, the scoliosis population who have true syrinx and you're catching early, I think they do have fairly good chance of having a good outcome and being symptom-free. I think the patients who have purely occipital headache as their only manifestation, that it's truly what we call Valsalva-induced, meaning when you're doing things to trigger elevated pressure in the brain, those also do very well. But I agree with you, whoever wrote the question, that there are definitely a large proportion of patients who don't feel perfect or feel better in certain categories, but not necessarily in others.
And the thing is, we would probably see those patients in our office and say, we've done a good job.
Yeah. Right? Yeah. So. And it depends on what you mean symptom-free. You know, questionnaires, intake questionnaires, when you come in and fill out those forms, they have a long list of symptoms usually. We don't know that each symptom is related to Kyary. So if you want all the symptoms that you've checked off, I think that's unlikely. Having Chiari-specific symptoms and some people completely resolving. That seems to be the case in some. We don't know the percentage. It might be useful to quickly, very briefly, read a list and comment. We published this in 2004. A nurse practitioner looked at 265 questionnaires that people brought in. And I'm just going to go over the symptoms that at least or more than half the patients complained about very briefly. Clearly, number one is headache, dizziness. Now, difficulty sleeping. If they want to get rid of that, there are certainly probably other causes, is what I'm trying to say. Weakness in the upper extremities, neck pain, numbness and tingling, nausea, fatigue, shortness of breath, blurred vision, tinnitus, difficulty swallowing. So over 50% had all those symptoms. Some, if they are swallowing okay and now come in with their Chiari syndrome, if you will, and have difficulty swallowing, yeah, the swallowing center's right underneath the cerebellar tonsils, etc. So some we can link to Chiari itself and hope they'll improve if we relieve the compression. But others, like sleep, chances are my surgery's not going to help in sleep.
Okay, question 44. Are there tests that can be done in utero to detect these conditions? So meaning Chiari, EDS?
Yes and no. So with Chiari 2, which is a very specific type of Chiari that is associated with the spina bifida population, you can pretty routinely pick up the Chiari on ultrasound. It's called the banana sign, and it's pretty consistent. In utero MRI is more routinely being done now in patients who have abnormalities identified on prenatal ultrasound. Those tend to be very significant abnormalities, and then if the in utero MRI is done, you can sometimes see these changes even early on, but it's a rarity. And the chance, I think, of an in utero ultrasound identifying a type 1 Chiari malformation is exceptionally low.
And you wouldn't recommend people who have Chiari to screen during pregnancy for Chiari in the
I
baby?
wouldn't, because of the implications that come along with it, and it's so inaccurate. For instance, half of my patient population is seeing patients who are diagnosed in utero with a variety of conditions that actually don't prove to come to fruition postnatally. So you don't want to be giving diagnoses to people that they don't actually have, or telling them they don't have a problem they actually do. It's just the sensitivity is so low, I wouldn't recommend it.
Okay, next question. Sorry, go on.
In regards to the pediatric, I noticed that a surgery for spina bifida was just performed last week. I don't know if you had seen that article or not, and how your intake is on that. It was performed
In utero? Yeah, there are.
Just to make sure everyone heard the comment. So there's some in utero surgery that's been done for spina bifida, and there's a comment.
Yes, there's a few fetal centers across the country that if the baby is diagnosed as having spina bifida early enough, and there's certain criteria, they can do an in utero closure. Now, there are risks to that in utero closure, including preterm delivery, which has its own set of complications. And the questions we're currently trying to answer are, is there an improvement in a variety of things then postnatally, one being hydrocephalus, another being the rate of Chiari, the other being functional level. Some of them are very controversial, and that includes the hydrocephalus, but I can absolutely attest that the Chiari is better with the in utero closure. 100% of patients with spina bifida before these in utero closures had Chiari malformation. I can honestly say that every in utero closure I've seen thus far does not have a Chiari. So I think that's one clear benefit of that in utero.
But for Chiari 1, I don't think we'd be contemplating in utero surgery. Next question, 45. Should I have pregnancy delivery concerns?
So my nurse practitioner, I think, reported the first group of patients. It was just 8 back some years ago. We found no issues there, but that was a limited number. I will, since it's a fascinating issue, I will ask you to search delivery in women with Chiari 1 malformation, and I think you'll find this study. There were 63 patients, or mothers, if you will, 95 deliveries altogether. 44 were C-section, 51 were vaginal, and the bottom line is that there were no issues in delivery regarding whether you want to have a C-section is recommended or a vaginal birth. So occasionally I'll get called by an OB-GYN in the Denver area, and they have someone that's close to delivery, and they have a Chiari 1 malformation. What can they do with anesthesia? And I allow them to make the decision on their own basis. However, and we'll see what Dr. Reynolds has to say. However, if it's a prolonged labor, and that's stressful to even me to hear about it, that maybe that's an option.
That's a tough one. I occasionally get questions from OBGYNs as well. I think the one population I may have a lot of concerns about are the people who are really symptomatic, and Valsalva mechanisms tend to make their symptoms worse. If it's a prolonged delivery, 3 hours of pushing, I don't think it has any overt risk to their long-term neurologic function, but they're probably not going to feel very well during that process. I don't think it would change my recommendation about the route of delivery per se, but just to acknowledge that they may have challenges during it.
I must say I do give one very specific piece of advice for a patient with Chiari malformation, particularly if it's a severe malformation and that has not been treated. I tell them not to have an epidural anaesthetic, because there are definitely cases that have been reported where if the epidural, if it's spinal, it goes through the dura and CSF comes out, there is a definite risk that the Chiari malformation will rapidly descend and cause significant compression of the brainstem, upper cervical cord, and cause either death or quadriplegia. Those cases have happened, so that's the only piece of restriction of activity or anything that I tell my patients.
And thinking about my own cases, I have occasionally heard, I asked one mother, she had her 2-year-old son sitting next to her, how long have you had Chiari symptoms? Ever since he was born. Yeah. From a prolonged labor and the increased crowding that occurred. Now that's rare. I saw some open mouths here for a minute. It's rare, but nevertheless.
And those patients often have had an epidural, and then they've complained about a low-pressure headache.
I totally agree. When we look for CSF hypotension, that condition of the brain sag that's not truly Chiari, looks like Chiari, then one of the things in our questionnaire is, have you had epidural, have you had spinal surgery, have you had a spinal injury, et cetera. Those give us clues to make sure we're analyzing for CSF hypotension. Uncommon, but a risky disorder.
There's a question, yeah.
Kind of piggybacking off the whole epidural thing, what is the stance for LP lumbar punctures?
I tell them the same thing, not to have a lumbar puncture. And that becomes difficult for us if we're contemplating or trying to decide whether the patient's got idiopathic intracranial hypertension as part of their syndrome. So if they've got a severe-looking Chiari malformation, I'm very reluctant to measure the pressure by doing a lumbar puncture.
We've evolved a little bit on that issue, just by force almost. So I had a young man in our community who had a fairly severe Chiari malformation. I think it was around 16 millimeters, fairly pointed. He was a little bit transient, if you will, so I lost contact for a few months. He was admitted to another emergency room in town. He let them know he had Chiari. They were able to reach me. They thought he had meningitis in the ER, and I said, number one, I'm glad you let me know because I'm here in town because you worry about it. I said, obviously, if you're worried about meningitis, you've got to do an LP, use a thin needle, only a few cc's. Fortunately, it turned out he did not have meningitis, and he did not worsen in his Chiari. So because of our concern of pseudotumor cerebri, and I have some out-of-state patients, let's say, what I've been doing lately is, even if their eye exam is negative, they don't have papilledema, is I've scheduled their surgery as second case of the day, and then in the morning they come in and have a controlled lumbar puncture by our radiologist, thin needle, only pressure measurement. And basically 4 out of 5 of those, I can proceed with surgery in the afternoon, but I have identified about 1 out of 5 that have raised intracranial pressure, no papilledema, and then we have canceled the surgery. The last a few weeks ago was a nurse. She was very upset initially because she traveled out of state, but recognized that there are some cases, I won't go into the literature, that if you operate in the presence of pseudotumor, in other words, you've got a brain swelling condition, you can certainly have stroke, loss of visual cranial nerve function. Not many cases, but nevertheless, it's important to know.
But I think we're not saying, correct me if I'm wrong, that the vast majority of people with a Kyary can't have a lumbar puncture. So most
Correct.
people with a
Yep.
Kyary can have a lumbar puncture,
Yep.
and you do see this, that people, you get rung up and said, oh, hold on, this patient has a small Kyary, they're asymptomatic. Is it safe?
Yeah, and so for those, I look at the scan. I pull up the scan, and it's a judgment call. And, you know, if it's not significant, I say fine. Yeah.
What about post-surgery?
Post-surgery, no restriction from me, if it's a good result.
On the other end of the pregnancy delivery, has anyone seen a correlation between traumatic forceps delivery causing?
Chiari Malformation. So can I answer that first? So Bernard Williams, I think, wrote on this and reported, I think it was Bernard Williams, wasn't it, reported some correlation between traumatic birth and Kyary. Personally, I have seen some cases where the scan looks like Chiari Malformation, but at operation, it's clear that it is significant arachnoiditis. And then you go back and there's actually a history of traumatic birth with neonatal hemorrhage. And I think in those cases what's happened is that there's been a hemorrhage, trauma, that's resulted in scarring that's tethered the cerebellum in place, and as the person has grown, it has come to look like Chiari Malformation. So it's not as if the forceps delivery has caused what we generally think of as Chiari Malformation, but it's caused scarring that makes it end up looking like that. Does that ring true for you guys? Never seen it? No?
I've not seen it, but it certainly seems to make more
I
sense.
can show you. I've got some cases that are very specific. Yeah. Does that answer your question?
And just following up neural studies on kids that may have had a traumatic forceps delivery. And I don't think that that's regularly done at all.
Right.
Unless they have a huge incident that makes you have to go to the
And to be perfectly honest, as a person who treats a lot of hemorrhagic conditions that happen after birth, I don't know that you could fully attribute it to the forceps. I mean, we see natural delivery without assisted devices cause hemorrhage postnatally all the time. So whether it's just the traumatic process of delivery.
as being the reason, the pull.
But in your case, I think we were assuming that, yeah, in those specific isolated incidences, I don't know that you can even say it's formally the forceps.
No,
Yeah,
I'm
delivery's
not saying forceps, but
so traumatic.
something has happened. And premature kids have hemorrhage without any apparent mechanical disturbance, right? Yeah. Okay, question 46. The question is that symptoms change according to posture. Could this be a difficulty with CSF flow? Andy?
I really like this question. I like the second half. I think this osteopath must have magic fingers
Yes.
to be able to test the CS, to be able to feel CSF flow.
Yes.
So, yeah, people can have different symptoms upright and lying down or sitting up as those who have the condition know. Why is it? Can it be related to CSF flow? Yes. You do see, certainly there's been a lot of interest in upright MR, and I see a number of questions about upright MR in this. I've had a few patients to go to with upright MR. The vast majority of them, there's no difference, but I've got the occasional patient who's very symptomatic upright, not symptomatic lying down, and you see a difference when they're upright than when they're lying down, which makes sense, doesn't it? You know, all our imaging is done lying down, or the vast majority is done lying down, where most of our time when we're symptomatic is upright. The other thing I think, though, is it doesn't say within the question whether this person who's asked the question has had surgery or not. And if they haven't had surgery, then sometimes when you have symptoms that are different, standing up and lying down, you need to think of other things as well. So certainly, for me, a lot of this sort of a question I'd need to take a sort of proper history, examine the patient, and go into detail why it is. Because sometimes if you've got a degree of hydrocephalus or even a low pressure situation, then that can give you different types of headache if you're upright or lying down. It's not always necessarily related to the Kyary, is what I would say.
Can I ask Lynn maybe to comment on this in terms of the physics and tissue properties kind of perspective, does gravity make a difference, do you think, of in terms of the movement of the cerebellum and the movement of CSF flow? Because, I mean, the studies that we have been doing all been on patients lying down. Do you think it's likely that it might be different if they're upright?
I think the short answer is we don't know.
Yeah.
And it probably depends very much on the details of the anatomy at the craniocervical junction and, you know, how free the cerebellar tonsils are to move. I think in people whose foramen magnum is extremely crowded, I think it's unlikely that it's going to make a big difference. But, you know, it's not beyond the realms of possibility. And certainly gravity's, you know, got the potential to move the position of the tonsils and everything. The other thing to remember is just simply moving your head, flexing and extending your head moves your spinal cord and brainstem up and down, and that can reposition things a little bit as well. So posture definitely changes the anatomy, and it could affect CSF flow, but we haven't measured that, so we don't actually know the answer.
And briefly, when we're up, then we have a little bit less intracranial pressure. So patients with pseudotumor, the brain swelling condition, can have a rougher morning than they do later on in the day, mainly because they're more upright and they have a little less intracranial pressure.
Okay. We've got about 10 minutes left for this part of the session, so I'll try to skip through pretty quickly. I think 47 and 48, I think we've covered those. 49, the question here is, can an MRI miss a CSF leak? And the answer to that question is absolutely. Detecting spinal CSF leak is a very difficult thing. You got any magic answers on the panel?
No, other than there are a series of articles available to us. They're hard to find, and someone needs to do a review of that. I guess I'm volunteering. But there are a number of lines and angles that are helpful, but it is still a difficult situation. There's a line from the pituitary fossa to the back of the tentorium, and that's very helpful to me because it's a quick line to be able to at least get the initial perspective of whether they could have hypotension. So anyway, in summary, there are a number of subtle, sometimes not subtle changes of hypotension. And I will say there are patients who've worsened in their Kyary after surgery who then the spinal fluid leak was found, treated, and the brain floated back up because, again, it's not leaking out of the sac.
But these are hard things to find.
Yes, I use my neuroradiologist. We all work to strengthen the people around us, the neurologist, the neuroradiologist, to have an interest in Kyary. But if I go see the radiologist across the street where the hospital is, I'm there once every 2 or 3 weeks with a case that this seems to point to it, that doesn't seem to point to it.
Okay, question 54. Is there a disability tool that measures impact that is part of surgical criteria for intervention? So, John, that would be right up your field.
Yeah, there are 2 outcome scales briefly. The Chicago Kyary Outcome Scale, CCOS, and then our scale is the CSP, Kyary Symptom Profile. There's some groups that are trialing these scales, and will, I think, long-term have a better idea of whether they're good enough or whether we need to evolve to even more specific. I think from the discussion in this group in the past few days, I think we need clearly scales that include specific symptoms so we can all answer for ourselves and especially for people affected, what is the likelihood that my hearing will improve following surgery, as an example.
I might just add that we're increasingly trying to ensure that the research studies also use those scales so that they're consistent between the research and the clinical studies as well.
Okay. 55, how often should a patient who's had treatment see a neurosurgeon for follow-up? Personally, if it's just Kyary, there's no syrinx, and at the I do a scan at 3 months. If the scan looks good, they're clinically fine, I discharge them.
2 months, Kyary only, and I discharge them if they're doing well, encourage them to follow up with us if they have changes.
Wow, I'm really wasting healthcare dollars. So, yeah, I'm doing children too, so we're often children. But I see them at 3 months with a post-op scan. If the post-op scan looks good and they're clinically doing well, I'll see them just clinically on a yearly basis for about 4 or 5 years just to make sure they don't have any decline thereafter. If the scan shows concerns, the syrinx didn't get smaller, they're having more symptoms, I may base my imaging frequency a little bit differently based on that. And on occasion, in the patients who I think are doing well but still have these atypical symptoms, I may repeat the image at 5 years just to make sure, but it's variable.
If they're fine, I see them once with a scan discharge.
Yep. Okay, 60 and 61. Why do you see the back of the head pulse after decompression? Is this common? And what, I think 61 relates to the same question, what triggers it to become more intense without physical movement?
So briefly, that's concerning to me if you can feel the pulse back there. What it often means is there's what we call dehiscence of the muscles. We all have quite a bit of musculature and what we call fascia or ligaments, if you will, that support the base of the skull. And if the closure of the muscles wasn't solid or it gave, then there's going to be very little coverage. And sure enough, these folks can tell the weather before the storm comes all the time because they seem to be more connected to the atmospheric pressure. So anyway, have someone show you your scan and see how much tissue coverage from the muscle and, of course, the skin is over that. That might give them a clue. The treatment for that would actually be to put at least what we do, is a Kyary plate up there and then really try to reclose at least some of the musculature to provide natural support.
And the other reason that people can get a pulsatile swelling at the back of their head is either that they had a leak from their valve, or in the UK there's still a number of my colleagues who believe that you don't need to close the dura. We've discussed this at the meeting. And so you have what's called a pseudo-meningocele, which just means a big collection of fluid there, and that can also lead to pain when you're lying down and pulsatility.
So I know we haven't covered all the questions, and I think we've covered, though, most of the themes, and so there are some further questions there that we probably can't get to. I thought for the last 5 minutes it might be best just to open it up to more questions that you've got now, rather than sticking to the prescribed for the questions. No?
We did that good of a job.
Hmm?
We did that good of a job.
Yes. Yeah.
So I know there's been a lot of people talk, you say that there's not always a correlation between the size of the herniation and symptoms, but there's also a lot of frustration amongst patients going doctor to doctor with getting a measurement of their Kyary. Is there talk about trying to get something that's consistent across the board between doctors to be able to measure that consistently, or I guess it's just sort of a...
Yes, I think, as I said at the beginning, there's a recognition that there is a need for objective criteria. We're not quite there yet, but I think we're making progress.
And briefly, ask your doctor to not just show you the side scan, show you the cross-section scans, and if they have them, the scans that are in the frontal projection, if you will. Because as we talked about this in a meeting and a number of presenters, it's a three-dimensional disorder, and yet we're used to just looking at that one. So somebody with 4 millimeters, if that stopper is tight enough at the top of the bottle, they can have a syrinx develop even.
Not everybody on the panel may agree with this, but when I meet with patients, I show them the pictures and I tell them, okay, this has basically answered the question that you have a radiographic Kyary. Yeah. After that, it has 0 value. The number means nothing. It's really how the patient symptoms are, whether they can be correlated to it, what their examination is. There are other imaging features that are helpful, but overall, the only thing it tells you is that you have a radiographic Kyary. And outside of that, it's not all that helpful.
So I 100% agree.
And I agree.
I think that's part of the issue that patients suffer is going from doctor to doctor, that it isn't a clear consensus across the board.
So the Kyary medical community needs to pull together. This is clearly a step in the right direction. There may be more steps in the future. It has become a subspecialty area of its own. We need to act like a subspecialty area and to deal with the frustration that many of you deal with on a day-to-day basis. I am winding down my practice this year, but the mission is, obviously with a lot of collaboration, is how do we get the standard knowledge base into the hands of the medical practitioner, the neurologist, the neurosurgeon that doesn't do much of this. I think that's our next mission over this coming decade.
Okay, so one more.
I have a daughter who I think may have a Kyary, taking her to a neurologist. They just look at the MRI, they're like, she doesn't have a Kyary, here's medication, treat it. But as a parent, what do I, like, and then you're accused of doctor shopping if you move around. Like, what's a recommendation for a patient?
You have the power to ask questions. The era we are living through right now is a rebalancing, if you will, or it's a balancing, okay? The power or the authority has been in the medical community. It's been very hard for the public to access, even myself and other disorders. That's changed with social media. Obviously, social media has its own issues as well, okay? But you can now use PubMed.gov, and basically when you are with your physician, one of the questions was, what can I ask? You can ask anything you want. How many cases have you done? What are the chances of improvement? How do you know those chances? What are my risks? And if the doctor starts rolling his eyes, then it's time to find someone else.
And I would strongly recommend you advocate either through your PCP or that neurologist to have a neurosurgeon look at your scans. And I 100% agree. If a patient asks me if they can get a second opinion, you don't have to ask for my approval. I encourage you to, because if we are going to go down the surgical route at any point, you want to feel comfortable that you did your due diligence and that, God forbid, we do run into a complication, you felt comfortable that you made the right decision based on multiple recommendations. So, this is your healthcare, this is your daughter's healthcare. I think information is power, and you should absolutely be able to ask for another opinion.
We do need to stop, I think, for a break. You've worn us out. We've probably worn you out too. So, look, I think that's been very useful. Hopefully you've got from us some valuable things, and certainly I think we've got from you some valuable things as well. We're going to take a break for 20 minutes or 20 minutes to half an hour, and then we'll reconvene and talk about EDS and then syringomyelia CSF.